I'm Joel Kahn. I'm a medical doctor. I'm in my office in suburban Detroit, Michigan. I grew up a mile away, but wandered to Ann Arbor, Dallas, and Kansas City to become an interventional cardiologist 30 years ago. Practiced heart attacks, 3 in the morning, cardiology, crazy stuff. And about 5-6 years ago, voluntarily became a complete preventive cardiologist. Rarely go in the hospital. I was there this morning to see a patient. At age 18, totally, somewhat randomly, I adopted a complete plant-based diet. So this has been a 43-year journey for me. Go try and find a plant meal in Dallas or Kansas City or the VA hospital. It's been a long and interesting journey. I think I've benefited well health-wise from it. I can't lift the weight Sean does. I don't try to. I don't work out. I still have, unfortunately, 12 hours a day of medical practice and other things I do, but I work out every day. And for 61 years old, I'm in pretty darn good shape. Keep fingers crossed. Hey.
Yeah, sorry. I guess my attempt to sit in the horse barn was not close enough to the Wi-Fi signal, so cut out. So I'm in a place that's better. Sorry, I apologize for that.
Right. I was actually, they asked if I'd introduce myself, so I told them that I'm a former vegan who's recently adopted a carnivore diet. We'll be leading the randomized study. But I'm just bringing up to date about a preventive practice, a long journey personally with plant diet, and and I think they probably knew that, but there was a question to do that, so they're pretty up to date.
And I think most of us fully support anyone's sort of right to do so. Pick the diet that works for you. I think that's something that I think within this community we're all about. Let's push for health. I think that's the main goal. So certainly, if it works for you, it's completely within your right to do so, and I think that's fine. But back to what I was trying to say before my Wi-Fi cut out. So we have this coronavirus, we have this COVID-19 pandemic. We've got everybody that's whether you agree with mask usage or not. I don't want to get into that. But do you feel frustrated, as I do, that we seem to be missing, or do you think there's an opportunity lost when we're not talking about host robustness? Obviously there's a virus, there's a vector, and there's a host, and we sort of completely ignore the host. They point out, hey, obesity is associated with a 12-fold mortality, and diabetes, and so on and so forth. And obviously the older people we're not going to make old people not be old. I mean, we could improve their health markers, but do you feel that we've not strongly enough as a government, as a health, when we talk things like CDC and all these other organizations that are directing the response to this pandemic, are they dropping the ball by not seriously saying, hey, look, it's really a time to, in addition to wearing masks and socially isolate and all those, or social distance, should we also be more strongly talking about these other things?
Yeah, I completely agree. I've written an article or two on that. I speak about that. I actually just got off the phone right before I logged on with a friend. We were talking about that. I think, there are these areas of soft underbelly that then get blown up and destroy the conversation you just had and I just had, which is, can you boost your immune system? And as an MD, and I know as an MD, we know some people have strong immune systems and go years without flu and go colds and never miss work. And we know those people that are in the hospital with shingles and viruses. Yet, as you and I know, but some of the listeners don't, it's very difficult for a practitioner to actually measure your immunity. Is it your white blood count? Is it your immunoglobulin level? Is it your C-reactive protein level? So can you boost it or not? We don't know. And I just answered this other gentleman, just like you just said. Well, we know the risk factors seem to be, and the risk factors, we don't know that they're causative, being obese, diabetes, advanced, maybe hypertension and therapy, probably not, but that came up. Advanced heart disease, yes, we can't make you younger. But what if we really did focus on optimal nutrition, lowering diabetic rates, lowering obesity rates, and is the path there that important? Can we disagree that there's more than one path to trying to reverse diabetes, obesity, high blood pressure? It's certainly not the standard American diet. I think we're losing a big opportunity. I never want to see a Wendy's burned down in Atlanta, but I'd rather we lock down fast food restaurants and processed food vendors than we, lock down necessarily more children in the American public. Although I agree, you got to do all the hygienic measures. Yeah, I think we're missing a big opportunity. You know, I wrote a little article about it. I mean, we don't know, is vitamin D optimal important? Probably. Do we know for sure? Not yet. There's actually some interesting data that omega-3 sufficiency may be important for proper immune performance. That's something that could be measured and enhanced. You want to eat fish? I'm not going to yell at you. You want to eat some hemp? I'm not going to yell at you, or flaxseed. You know, maybe, you know, blood iodine levels. There's things that you can measure nutrition easily. That's what I do in my practice. So I think we've completely missed the boat, with some rare voices about, let's get America healthy. I mean, that would be an unpopular phrase to make America healthy again. It actually has come up, but we know that's politicized, so we'll stay away from there.
Yeah, I don't disagree with you about, you know, how do we accurately measure immunity, but we can certainly, you know, have a good idea of who's at risk and what those things are and how to measure those things. You know, obesity is pretty easy to measure. Diabetes, blood glucose is pretty easy to measure. These things, you know, inflammation markers, pretty easy to measure. And so you know, I certainly agree that we dropped the ball on that. Would you, I mean, I think you and I both, you know, even despite the fact that you are still practicing in an allopathic system and doing the cardiology and, you know, but you would consider yourself primarily a lifestyle guy. Would that be fair to say?
Yeah, it's always the first choice, except in urgency. If you got a fractured femur, I'm not going to, you know, talk to you about eat more, anything specific. And if you're having a myocardial infarction, you know, with that exception, the vast majority of outpatient medicine should be lifestyle medicine, with prescriptions and operations being, you know, when that fails. And that applies now. You know, this is reminiscent, but you know this, but your audience may not. I had to go head to head this morning with a very prominent cardiologist in San Diego who was going on and on about anybody mentioning hydroxychloroquine should go to jail. Now, I'm not telling you I'm not an infectious disease doctor. I just don't think sequestering speech is a good idea right now in medicine. And what I responded to him, because I've known him for 35 of my 43 years in kind of medical training, I said, you know, Eric, I just revealed his first name. I said, you know, 43 years after we got the first heart stent, or at least the first heart balloon, we still debate the proper use of stents and angioplasty, and there's clearly too many. And you're telling us within 5 months of developing a pandemic, we can't, you know, have a debate about the use of a drug that might be helpful. It's just unfortunate it's been politicized. So I just want to make a point before we leave there. You know, I'm a cardiologist. I spent 25 years and then several before that training, putting in stents, treating heart attacks. In April of 2020, a $100 million research study. You're trying to raise 200,000, you know, so wish you well, maybe contribute. But this is a $100 million cardiology study. You have advanced bad heart disease. You failed your stress test. You have angina, real deal. And they weren't subtle stress tests. These are ugly. And you're randomized to medicine, diet, and walking, or you're randomized to early bypass and stenting. 3.5-year results were published in November, but fully published in New England Journal of Medicine. So far, not retracted from the New England Journal of Medicine in April. There was no difference in survival. In fact, you were more likely to die early if you went for early stent and bypass. There was no difference in hospitalizations or all. There's a little better quality of life in terms of possibility of further chest pain. And yet, has that impacted anything about decisions and utilization and billing and patient conversation? No, I think it's a horrible, horrible, you know, example where we missed the boat completely. And lifestyle medicine was proven again, you know, and that was not a plant-based randomized study. I mean, they were encouraged to eat a lower saturated fat diet, but it was really pretty wide open. So yeah, we missed the boat, lifestyle medicine, and avoid medication unless it's urgent or there's no response.
Do you, I mean, obviously there's a wealth of, you know, studies out there. I mean, who knows how many studies are done every year? It's in thousands upon thousands of studies. Do you find that there's some degree of conflict of interest, particularly coming from pharmaceutical companies? Do you feel that impacts our science at all? Do you think there's some of that going on?
I do, and maybe I'll bring up something, and, you know, not to be contentious and uncomfortable, but, you know, to do a big study like I just mentioned, somebody has to fund it. Even to do a modest study, you know, it either has to be a grant from a foundation, National Institutes of Health, private donors. There's a example, a researcher in New York City has been trying to do a study to demonstrate, does the diabetic drug metformin have anti-cancer pro-youth abilities, which there's a lot of reason to believe, but it was going to cost $80 million to do a 4-year, 4,000 patient study. He got a private donor to pay for it. Now, I don't know if the private donor has a bias, but that's the kind of challenge you go through to do a quality study if you don't get a grant from the National Institutes of Health. They don't really view aging as a disease, so they don't fund much aging research in Washington, D.C. or Bethesda. But so, to get research done, you want to study walnuts, it's probably going to be the Walnut Board. You want to study avocados, extra virgin olive oil, it's probably going to be those foundations. And so I will bring something up to be contentious a little bit to, let your group know. The debate over whether saturated fat-rich diets raise cholesterol leading to atherosclerosis has been a conversation since at least 1955, 56, and possibly earlier. And the famous, I think, honored Ansel Keys, PhD, and other people would call infamous, did a lifetime career that concluded lower saturated fat diets lead to lower cholesterol, lead to lower heart disease worldwide. He was maligned by a lot of people. Interestingly, his Wikipedia biography has been cleaned up and much more, I believe, my bias, authentic, although I don't know him and I don't know his family. So the debate has been raging since 2010 again because of a couple research papers and Nina Teicholz and all, and we can go down that path if you want. But about 5 weeks ago, it's called the Cochrane Library, Cochrane Database. Many people consider the least biased, the least funding conflicted group that does big systematic reviews of a topic, from folate in pregnant women, in this case, saturated fat. They concluded that the studies they found that were quality, lower saturated fat led to a 21% drop in overall cardiovascular risk. The lower you went, the more the drop was. And that was published. Not one network in the world picked up on that. I just happened to be reading National Library of Medicine and saw it and wrote a couple papers about it within a couple weeks. And I think coincidentally, published in my journal, American College of Cardiology, was a viewpoint. Saturated fat doesn't cause cardiovascular disease, and included Salim Youssef, MD, very prominent epidemiologist out of Hamilton, Ontario, had Jeff Volek of Verta Health, and well-known low-carb researcher. 12 authors, 9 of the 12 declared that they get direct funding from dairy and meat foundations. I don't know if it biased their paper. That's a pretty big number, 75% of the authors. And then a week later, there was another viewpoint. Now, what's interesting is the media picked up on the last two sensational viewpoints. They didn't go for what generally is considered the highest quality. It's an example of, the problems with bias, the problems with the media, the problem with trying to separate hashtag fake news, hashtag real news. But are there people that get funding and actually do good research that sometimes conflicts with the group that provided the funding and still have the ethics to promote? I think that happens. I mean, David Katz, MD, has taken funding from the egg industry and has done some research that suggests eggs are not the greatest source of cardiovascular disease. But he's been open and honest that most of us, I do own a very tiny plant-based restaurant. In fact, I just came from there. I don't know if you saw on social media, I was going to threaten you with my barbecue tempeh sandwich, which in your case would be a barbecue sirloin probably. But I don't own broccoli stock. I don't own sprout stock. I mean, I have a viewpoint based on practice, science, some issues of the environment, and just it's a very anti-processed food, very anti-crap American diet viewpoint. But I'm talking to you because to say that it has to be the only path is rather reductionist, and I don't know that. I won't say I don't believe it, but I don't know that. I want to see your study funded and done, and it's a good thing.
Yeah, I'm just to that. And it's not my study. I mean, we're going to have professional researchers that are going to do it. I'm not a researcher. I'm not going to pretend I am. We've got a number of researchers that have definitely expressed interest in doing it once we get it funded. So it'll be a professional study done by actual research professionals. And we want to do an RCT, and we want to have, obviously, proper controls and good robust endpoints, and let the chips fall where they may. Let me ask you, let's just shift. Okay, so I mean, obviously, you got the JACC Journal of American Cardiology study that came out recently saying saturated fat's not bad, and you say maybe it's because of conflict of interest, but let's just say maybe it is, maybe it's not, and I could, we could go back and forth on who has conflicts, and I would say there's a lot of studies that the Adventist health systems put out, and I'd say they have a conflicts of interest, and we've got,
Right. You can talk about Harvard School of Public Health. You can talk about it.
Yeah.
Right.
So we can all talk about conflicts there, but let me ask you just some stuff. Obviously, I'm going to defer to your cardiology knowledge, because I sure as hell am not a cardiologist, and I think you've probably looked at this more than me, although I've looked at it a lot. Let me ask you, in your view, why do we have LDL? What is the function of LDL cholesterol? Why do we even have it?
It's a good question, and there is nobody on the planet that doesn't have LDL cholesterol. You go to hunter-gatherer populations. Some would call the father of paleo diets, Lauren Cordain, in his book, The Paleo Diet. I have it in my office a few feet away. Talked about the optimal LDL. I think it was a paper actually in the American Journal of Cardiology with a MD cardiologist, James O'Keefe, who I trained with. The optimal LDL to prevent cardiovascular disease, Lauren Cordain, is an LDL of about 50. I mean, that is actually hunter-gatherer data, the orientation of their paper, where the Hunzai and the Yanomamo and all. You absolutely need LDL. Cholesterol is the backbone of cortisol and vitamin D and sex hormones and optimal brain health. I mean, the cardiology community is not divided. Fringe voices exist. The cardiology community is lowering LDL in healthy people lowers risk, lowering LDL aggressively in people with heart disease lowers events. The European Society of Atherosclerosis has pounded this down the last few years. And I will say there is a pharmaceutical industry, statins, which I'd rather you control your cholesterol with lifestyle than with statins, but they have a role if you watch for side effects. Statins are generic now, and they're pennies. In fact, there's been times they're free. So money isn't the big driving force on statins nowadays. Now, there are new cholesterol drugs that are expensive and are driving profits, but there's a lot of hoops to get insurance approval for, because the contrast of free statins versus expensive newer drugs is an issue. And I struggle to get some of these people on the newer drugs. So, I mean, its purpose is a backbone for important hormonal function. But is it a U-shaped curve? None, but there really nobody has none, too much, and a sweet spot. And right now, the sweet spot is individualized. You have a calcium score of 0. I would be much more liberal with your LDL than somebody who's had bypass surgery 4 years ago in terms of my consensus. And I will tell you, it's no secret. You can eat Dr. Esselstyn's whole food, plant-based diet and still have an LDL above goal, because you produce more cholesterol than average. It's called hyperproducers. And you use a statin or you use natural agents, but it's just you tend to have a lower LDL cholesterol with a plant-oriented diet full of rich fiber, not full of Impossible Burgers.
And I appreciate you mentioning that U-shaped curve, because, I saw a study recently looking at people that naturally had LDLs below 70, and you put 50 as optimal, but they showed higher, at least this recent study, and I don't know if you've seen it. I mean, there's so many studies out there, of course, but it basically looked at, these people that were, at LDL below 70, and it was non-statin treated. So they were untreated. They were basically either lifestyle or genetic. And the people that were below 70 had maybe a 300% increase in mortality, cancer, and
intracranial hemorrhage at times. But I think
well, we've seen that too. Yeah, we've seen that too. Like in the Japanese population, we've seen that. But and then again, at the other end of the spectrum, there was a rise. Over, I can't remember what the LDLs. Maybe it was over 160 or 200. But it was on both sides. So there was a sweet spot in the middle that we see that. And then we see these PCSK9 inhibitors, which can dramatically. These are drugs you can drop the LDL cholesterol down to 20, right? And right. Are we seeing guidelines directing people towards lower and lower and lower cholesterols because the statin patents are running out? Would you be as skeptical as to say that there may be some ulterior motive to sell these new drugs, that make a lot of money versus, you know, a statin that won't get you quite as low?
I, I, I actually don't think so. I think it's just progressive science. You're right. It used to be possible, but a struggle to get an average patient's LDL to 70 or lower after bypass, after heart attack. Now, if they qualify for the injectable drugs because they can't take statins or they aren't effective, you can get somebody's LDL to 35. And there's quite a bit of data because the FDA is watching this, and you know they don't do everything right. But the post-release analysis is not finding, you know, it's only 5-6 years since we've had those drugs, but we're not finding a bump in cancer, a bump in diabetes, a bump in dementia. Brain health has been looked at. Now, that's not 20 years of data. And it gets close to hunter-gatherer natural cholesterol levels. I participated, just to share, I'm not the world's biggest academic, but I published a paper in 2012 in the same JACC, Journal American College of Cardiology, with a British genius. He was the first author. There's a few genetic variations called SNPs. You know what SNPs are, single nucleotide polymorphisms. I just say that for your audience, that you tend to have a lower LDL cholesterol from birth, maybe 20 points than the average population, maybe 30 points. And there's a few SNPs that you have a little higher, not dramatically, just a little bit. And there's a database like this called the Biobank in England with, I think it was 350,000 people. Turns out if you have a SNP that through your whole life, you have just slightly lower LDL, you have a 90% lower risk of cardiovascular disease. Statins give you a 30% drop, but this was a 90% drop. So, you know, being a healthy eater as a kid, as a teenager, as a young adult, gives you an advantage far beyond just starting a healthy lifestyle at 50 or 60, but started at any time. And the same was true. Well, it's actually, we've now done it with the genetic cholesterol called lipoprotein A that isn't as influenced by diet, but everybody should have their lipoprotein A cholesterol check, $20 blood test. If you are born with a low level versus a genetically somewhat higher level, your whole life, the multitude of risk is actually much more dramatic. It's, you know, those are called Mendelian randomization studies. They're a very cool way to look at a topic you wouldn't easily look at otherwise. We can't do it. I mean, you can't say, let's take, well, if we could identify what in a carnivore diet changes biochemically and find some people with that SNP, and I can't even imagine how we'd ever do that, and then try and track without having to do a randomized study using genetics. But you know, I'm not aware of any possible way you could look at that question. But you can do it with cholesterol. You can do it with, you know, lipoprotein A. You can do it with people that genetically have high ferritin levels or low ferritin levels or some other, you know, biochemical marker. We got to think about that. We can go to Dr. Ferrens in England and say, can you model all that database? But we'd have to identify what marker is consistent with the result of a carnivore diet.
Yeah, and it is, as I pointed out for you know, my lipoprotein A was 2. I mean, it was the bottom of the bottom. So I mean,
Yeah, good parents. Look at you. You got great parents, Sean. You should praise them every day.
Well, you know, like I said, yeah, my grandparents lived to 95 on my father's side. My father and mother both in the mid-70s, still doing fine. So yeah, I do have some genetics. But let me ask you about this, because we like to talk about, you know, quantitative evaluations of cholesterol, LDL in particular. What about qualitative? Do you find that there's a qualitative difference? And would that explain why, like, for instance, I know you guys like to talk about FH, familial hypercholesterolemia, and we see some people that die at 15 with really high cholesterols, and yet there are other ones that spend their whole life with a cholesterol above 300 plus, and they make it into the 70s and 80s. So is there a qualitative difference in the LDL cholesterol? I mean, granted that there's a lot of data that supports it, that quantity makes a difference, but does quality make a difference?
There's a couple comments. I won't hold myself out as a world expert on familial hyperlipidemia, but you know, when I did my cardiology training in Dallas, Texas in the late 1980s, the two scientists who identified familial hyperlipidemia and had just won the Nobel Prize were there, Dr. Brown and Dr. Goldstein. So it's very honored to spend some time and learn from them. And at the time, we talked about 1 person in a million gets a gene from both parents. And, you know, as a kid, your cholesterol is 1,000. I took care of a few of those, a very famous one named Stormy Jones, who had a liver transplant and a bypass at age 11 or 12 for just, you know, old woman's heart disease and didn't make it past her mid-teens. And then there is in about 1 in 250, you just get one parent gives you the gene, and you might have a cholesterol from 300 to 600. And they typically have increased risk over life, but that's group populations. We also have learned more recently, many people that inherit the LDL elevation from the many genetic variations that lead to familial hyperlipidemia, it's more than one. They also have lipoprotein A quite high, and it may be, and it's looking like the early vascular disease, the unfortunate 19-year-old that actually has a heart attack. It's 1 in a million, but may have that combination, and it's a double jeopardy. But I just want to finish with one point, and I explain this to my patients over and over. Smoking is a risk factor for heart disease. There are people that smoke and never have it, and lung cancer. Diabetes is a risk factor, and LDL cholesterol is a risk factor. It's not the risk factor. It's a very subtle but very important differentiation. You can do everything wrong and still have a good long life. I always show a slide of Winston Churchill, obese, no activity, cigar, and he lives to 91. And Jim Fix, the runner, dies at 53. That's a classic side-by-side comparison of external appearance and habits never would have predicted outcome. Turned out Jim Fix had a cholesterol over 300 and had just horrible coronary disease that either he ignored or didn't know about. And I have no idea about Winston Churchill. So these are all risk factors. That's why I advocate, as you know, and you've done it, test, don't guess. Get a CT scan, get a carotid ultrasound. If you're doing a carnivore diet, get some lab work, get some cardiovascular testing, not to scare you off the plan, but since we don't have much data about the diet you're doing and cardiovascular, burden and outcome, we have, one-time snapshots that you fortunately came out good on a CT scan. And I think Paul Saladino just published a calcium score of 0. I mean, he's probably a decade younger than you, I'm not sure, but, we need follow-up. Just say, again, the idea that plant-based diets are beneficial for cardiovascular disease is easily a 70-year journey. And, and I know there's carnivores who have been doing this for a couple decades, but in general, your movement and the excitement behind your movement is, a couple of years old. I think in your case, 3.5 years old, but, it's not to scare people off, but the obligation, and if I haven't gone back and forth and then social media is, teach the brethren, unless you completely feel that LDL is irrelevant. And I would feel better about that if I knew somebody's carotids and coronary arteries were fine. And, just finally, it may be that a high LDL plus high C-reactive protein inflammation is, according to some research out of Harvard, a double jeopardy. So you want to know if the diet's working for you in a anti or pro-inflammatory way. And in general, plant-based diets are anti-inflammatory, but there are plenty of my colleagues and my patients that still have a high C-reactive protein.
And I would personally, I don't tell people that LDL cholesterol is irrelevant. I tend to take a sort of, it's a factor, it's a risk factor, right. And a lot of things we need to look at. Factor, yeah. And I think that, and I think this is something that I think is really important to look at. I mean, I looked at a study recently, they compared smokers to non-smokers and looking at the risk for, cardiovascular, subsequent cardiovascular disease. And it was something like doubled your risk, So right. That's pretty significant. But if they looked at CAC score and people that had high levels of coronary artery calcium, that it was even 6-fold higher than the smokers. So it's such you get so much more information when you actually look at disease versus risk factors. And I think that is, and obviously there's been a lot of criticism on coronary artery calcium scan because it doesn't show soft plaque. And as I'm sure you'll agree, if you have no calcium, then you're less likely to have soft plaque than if you have a bunch of calcium. I mean, that's also pretty clear.
The unique thing, and I do in my clinic, is I encourage people to go to the hospital, get a calcium score, but I do these advanced carotid studies. And, patient in the office yesterday, calcium score 2, pretty good. But, some 20% plaque bilaterally, that's probably a combination of soft and hard. So we still got to work a little bit on making sure at least that doesn't get worse. I try not to scare the heck out of people for mild plaque because, they're probably going to do fine in the long run.
And how do you, what has been your experience with the, because there's been some controversy whether calcium can reverse. There's some people that have anecdotally they've had that happen. That needs to be studied, and you need to do a proper study to really verify that. But with the CIMT, and then I know you talk about maybe a pulse wave. There's other metrics of vascular health out there. So can you give a couple that would be outside? Like, let's say people are here that they're like, hey, my cholesterol is high. I'm good. I'm fine with that. I'm okay with that. But but if that was you and you said, well, how would I verify that? Because I tell people, don't ignore it. Verify it with some other testing. How would you do that?
So great question. We talked about, and everybody knows, you can get a doctor's prescription and you can go to the local hospital. It's about $75 and get a heart CT scan. I don't encourage people that are 30, 35 to get one, but 45 would be a good idea if you got a bad family history. If you've had a heart attack, you don't need it. If you can find somebody to do a nice little carotid ultrasound, there's simple ways at the church. There's more advanced ways like we do in my clinic, whatever. And blood work, get a cholesterol panel, get a hemoglobin A1C, blood sugar average, get a C-reactive protein, maybe know what your vitamin D level is. You don't need to do much more than that, just to get a general sense. Now, I'm going to make you chuckle and blush, but you ask a guy, do you get erections? And if they change their diet and they didn't, and now they did, it's a pretty good sign. There's, not overwhelming data in the plant-based community. There's more anecdotal data. The published data is actually pretty small, but that would be a good sign. A little more difficult in the female community. You can check endothelial function with certain devices. I have one in my clinic, certain blood tests. That's not common, but it can be done. But I think really those basic tests are all you really need to do if you have concern. One of the world's lipid experts, who's really no skin in the game, is a true academic in San Diego, who's an expert on lipoprotein A, which is why I follow him on Twitter, posted 2 examples. And just 3 days ago, 2 people that adopted, paleo, keto, carnivore, and he just tracked within 4 weeks, he's the head of a lipid clinic, a pretty dramatic rise in LDL. He was only making the point, maybe 25, 30% of the population, when a diet introduces substantially more saturated fat and cholesterol, will have a pretty dramatic jump in their cholesterol. And maybe 70% don't, because there are what we call hyper absorbers and kind of normal absorbers. You'll never know, but I would suggest, like you did, I know it took you a year, but you got your labs done. It's not a really much of a biohack to get a few simple labs before and a few simple labs after. I don't know, I think Saladino, and I don't want to keep bringing up his name. I had to bash him a little bit when we debated on the doctor show, but he was just a little brash for the panel of doctors there. But maybe I'll talk about that, about hubris and honesty and humility of medical science. I don't know that, I think he's published his cholesterol's crazy. And I mean, he's young and he's lucky that he's got, calcium score 0. But, that's anecdotal, not to be ignored, but that's not how we, and you know it and I know it. The things you did in orthopedic surgery were years of, trial and error and improvement and progress and testing and science and research. You don't just come in one day to the operating room and say, I made something in my garage and I'm going to start putting into people. I mean, there's a process. So, new ideas get some time, get some grace. I don't think cases of one and anecdotes populate the Meet RX community are not science. I think they're science, but they lead to, let's formally test this, because the medical community won't accept it, whether you care about that or not, but they're not going to accept it until, there is some data. Maybe we'll learn certain genetics, certain diseases, certain, way we can predict who's most likely to benefit from this. Otherwise, maybe your whole community is just hysterical and, creative writers, but I don't think so. I mean, I don't understand how the diet works, but I don't think that everybody's making up the story.
Yeah, I think that, we have to respect the role of quality of life, and I would say, if I look at, quite honestly, much of the nutritional research, and then I really strongly point my finger at epidemiology. I mean, really, epidemiology is really just a series of anecdotes. I mean, it's self-reported data most of the time. It's what did you eat? What did you think you eat? So that is, certainly we can make that argument. And again, obviously, and what I'm trying to do is get a study going together, and I'm trying to advance the science of this, because I believe strongly in it. And whether I'm wrong or right, the chips will fall where they may. I mean, there there are literally people in this room that I mean, there's Tracy who couldn't walk and now she's walking again. There's Brett who had lifelong crippling, debilitating mental health disorders. Now he's happy, normal. I mean, there's all kinds of people that you're looking at right here. There's people that are diabetics that were, you know, hemoglobin A1C of 10, 11. Now they're 4.5, 5. So we're seeing definite quality of life improvements. We're seeing definite health gains within this community. Why it's occurring, I have my theories. I mean, some of the things, you know, whether it has to do with obviously removing the refined garbage. I mean, clearly both of our diets remove, you know, they're predicated on not eating a bunch of junk. That's clear. And I mean, how we define junk, and, you know, I mean,
are you under physical threat? I just want to make sure you're okay.
no, my dog was
Okay.
their neighbor came by, so my dogs are going to bark a little bit. I'm outside, so we see that, and we see that over and over again. And again, you know, you're right. I mean, I've seen literally thousands upon thousands of people now that are all singing from the same song sheet. So we're all either it's mass hysteria, it's a, you know, we've mesmerized the whole population. But we have people with,
it raises so many interesting questions, which is, again, I mean, I'm not going to scream at you. I mean, how do you know, the whole vitamin C thing, the whole fiber thing, the whole microbiome thing, you know, what other critical nutrients? You know, the plant-based community recognizes, I think all diets can be nutritionally deficient, and even a well-constructed, colorful, whole food, plant-based diet could be deficient in, if you believe that testing nutrients is even valid, omega-3, vitamin D, iodine, chromium, B12. And I test all these in my people, and some are low and some are not. And we supplement them. You know, if I can use food like more flaxseed, but if it's a capsule a day to get past that and optimize their levels. I mean, it's just, I'd send some carnivores to me. I'll get some lab work on them. Any Detroit carnivores, come visit me. I mean, don't have to see me. I'll just draw labs on you pre and post, because, you know, I've been drawing chromium lately, a mineral involved in glucose and cholesterol metabolism. Difficult to absorb, rich in broccoli. I can't give you the content of meat. I think half my patients have 0 chromium in the bloodstream, even though they're eating broccoli. There's just a difficulty in absorbing it, apparently. And it has, you know, and I see their insulin sensitivity return. Now, that's another question. Insulin sensitivity or resistance on the carnivore diet. These are not hard things to study, but maybe we'll get an academic carnivore PhD that will embrace some of this. And I think there's much to be learned without, you know, belittling it. It's just fascinating. I don't get vitamin C. Because I use and talk and teach about the role of vitamin C in collagen formation, arterial health, anti-inflammatory. Maybe during COVID, of course, people are talking about an extra 1,000 milligrams of vitamin C orally a day. So, I mean, is it still this glucose, vitamin C competition? And when you're eating carnivore, you're probably got a lower blood glucose, so vitamin C even trace amounts. Is that kind of the thought?
well, I mean, if you want to talk about that, and again, we can't sort of certainly say what we know based on what we know about human physiology. Obviously, there's glucose competitive transporters across many membranes, across the intestinal membranes, across mitochondrial membranes. We see that. We also see the carnitine, which is vitamin C has a crucial role in carnitine production, and we eat a lot of carnitine. We're on a red meat diet particularly. So you're getting carnitine. Some of the collagen precursors, hydroxyproline, hydroxylysine, which vitamin C does, those things are directly absorbed. We do have transporters in the guts for those, but we see often, this is another thing that's interesting. If you look at uric acid has clearly been associated with gout, and high levels of uric acid in some people, but not all people, will precipitate a gout flare. But like everything else, it depends upon the overall physiologic milieu as to whether or not you get that. Some people will have very high levels of uric acid and never develop gout. Some people will have low levels of uric acid and develop gout. So it seems to be, again, like many things, multifactorial. And one of the things we know is you may or may not know this, but uric acid is actually an antioxidant. It's one of the most powerful and most ubiquitous antioxidants we have in the body. And so there's some thought that uric acid, in a carnivorous diet actually, supplements the role of vitamin C. There is vitamin C in meat, even muscle meat. You don't have to eat organ meat. So, how much do you actually need? How do you measure vitamin C? Is serum vitamin C a very particularly useful measure? A lot of people would argue no. You might want to look at a white cell leukocyte vitamin C level, might give you more information. So even measuring vitamin levels And this is interesting. If you go back even 100 years, like something like thiamine, which deficient, if you may or may not remember, gave you beriberi,
Right.
which is either neurological, cardiac, depending on wet or dry. But they looked at animals, and animals that were on a higher carbohydrate diet needed higher serum levels of thiamine to prevent beriberi. But when they were on a lower carb diet, they could have lower thiamine levels and not to develop the disease. We saw that the same with different Inuit populations when it came to vitamin D. Those with that ate traditional diets had low vitamin D levels but did not develop rickets. But if they had diets that included the more westernized food, the flours, the canned foods, the sugars, their vitamin D levels were still low, but then they developed clinical signs of rickets. So even the serum levels may not predict clinical outcomes. And so I think it's much more difficult and much more nuanced even to say straight up what's your number. That's why this is so hard. Human nutrition is incredibly hard. And so to me, and I know I get a lot of criticism for this, but I say, you know, how are you feeling? How are you functioning? What's your, you know, and you make this point about erections. I think that's a very important point, particularly, you know, that's a canary in the coal mine, as you pointed out, and I have as well. And I can tell you, a lot of people in this community notice a tremendous improvement in that capacity as males. And you, again, as you're right, females are harder to assess that in, but, and that is eating high meat diets. So it may not be that the meat is clogging the arteries directly, whether or not it raises your cholesterol a lot. I'm sure, you know, I think the problem, in my view, Joel, is so many Americans fall into this metabolically sick category. They're inflamed, they're pre-diabetic, they have poor glycemic control, they have high inflammation, they have high visceral fat, and on top of that, they have high cholesterol. And in my view, because that's 80% of the population, if you just look at population dynamics, you know, 8 times out of 10, you're going to roll the dice and you're going to be correct because, yeah, their cholesterol's too damn high. I think when you have a population where their glycemic control is good, their inflammation markers are good, their visceral fat is good, their obesity is good, their blood pressure is good, their cardiovascular function as measured by things like VO2 max are good, you know, then maybe those people are at less risk than the standard couch potato sad person, which I'm sure most of the people you image are these sad people. I don't know how many carnivores, you know, that come in with all those good numbers are needing a cardiologist. I mean, again, time will tell. That's for sure.
I doubt, I can't recall, you know, and I think people would know I'd accept them even if they told me they're doing, I have a lot of paleo and keto patients, but I don't have anybody, I think, doing a 100% carnivore diet. And I agree with you. I mean, carnivore diet and smoking is going to be probably like a whole food plant-based diet and smoking. I mean, you're not going to necessarily get all the benefits that may be there. It's stacked risk factors clearly matter. Yeah, but these are fascinating topics. You know, I will say, just because I'm presenting a viewpoint, we have had such a flood. I wrote an article on LinkedIn because it's easy to post a blog on LinkedIn and share it anywhere. Maybe 10 days ago, 8 new studies in the last 2 months supporting plant-based nutrition. And, you know, one was on cognitive health, and one was on risk for Alzheimer's, and one was on diabetic risk, fruit for diabetes, and one was on longevity and aging. It was a review article. Well, anyways, in the last 2 weeks, 2 more articles came out, a 700,000 patient database, all the problems with nutritional epidemiology and databases, but, you know, a trend towards more whole food plant diets was associated with longevity. And then there was one, I haven't actually read this one yet, it just came out. Diets that are nearly vegetarian but still include meat and fish, lowered blood pressure compared, again, I assume they're comparing to the standard American diet. But, you know, that's why, again, the 70-year picture encourages people to eat the food plate of Canada, Australia, a largely whole food plant-based diet. You know, we don't have 70 years of carnivore experience. We're just, you know, getting started, but it'll lay out how this works. Are there some risks we don't know yet 2-3 years down the road? I'm not Debbie Downer, but are there some risks we don't know about? And I think it's just, again, try and just talk to people. You know, you can order your own lab tests. You don't have to, you can go to lifeextension.com. You can go to Wellness FX. You can actually fill out an order and pay for your own blood panel, your cholesterol, your blood sugar, your testosterone, your maybe liver enzymes. Like I said, maybe want to do C-reactive protein like you just mentioned. You know, be an experimenter. That's what I'd encourage all of you. And then you know, what the plant-based community has done, they're is published research, there are randomized studies, there are nutritional epidemiology, there's basic science, but there's a lot of case studies still. You go to forksoverknives.com, there's just, and I don't think they're unauthentic, they're just real people that have had real benefit. Now, you know, I mean, you're doing that, and I've never been. Is there a website, meatrx.com?
Yeah, there is. Yeah, we have a,
And are there, you know, testimonials, case reports, whatever?
Yeah, we've got hundreds upon hundreds of testimonials. It's resources. We've kind of compiled some of the literature that it obviously show things that which indicate that, this is potentially helpful for people. It's just a huge resource.
Waiting for my copy of the Carnivore Diet. I'll trade you my book called Vegan Sex if you send me your book called Carnivore Diet.
That's tempting. I'm tempted to do that. I might look at that. Yeah, but hey, let me ask you. This is something, Bill.
Yeah.
This is something that I think is a very important topic. And as much as I give vegans a hard time, because I just don't like the meat is murder and all that stuff. I disagree with that approach. I think that turns more people off from veganism than makes it support. But, one of the underlying, and again, a whole food plant-based diet is not veganism. Veganism is more of an ideology, and most people tell us that if you ever quit being a vegan, you were never a vegan. We hear that all the time. But, the thought is we're going to end animal agriculture completely. I don't think that's a realistic goal. And I think the better goal is, we look at some of the conditions, the factory farming, the battery chicken operations, the pigs crowded in. None of us meat eaters are saying, yay, 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 more of that. I mean, there are other options out there. There are better ways to raise meat. There are regenerative agriculture, which, and I can tell you, some of the people say that the naysayers say it can't be done. That's based upon traditional grass-fed grazing techniques where they don't properly pasture the animals. We know that when you properly pasture animals, you can increase the productivity. You could actually increase the meat production in the U.S. with the land we have, and even more so. We could do more if it's done this way. And so we all support that. Whether we can support it financially or not yet, that depends. But wouldn't it make better sense if the goal were more realistic and say, hey, let's as a vegan community support this maybe regenerative approach to animal agriculture, knowing that animals die regardless, knowing that, if we continue this crop-based monocrop, whether some of the grains are being fed to animals or fed to humans, that also leads to significant death. And I know people say it's by kill or it's accidental, but pesticides are not put on there unintentionally. Pesticides, the name itself implies killing things. And so you can do regenerative agriculture without pesticides, without herbicides. You can still grow food. The animals get a good quality of life. They live longer than they do in the wild. I can tell you a wild deer lives 12 months on average. 50% of them will be killed before they reach 12 weeks. 50% of wild deer are dead before 12 weeks. Wow. A cow in the U.S. system, 98% of them make it to adulthood. So they have a better, and if it's regenerative and pastured correctly, that is a far better life. And so I would like to see a group of both vegans and carnivores and say, hey, let's support this type of agriculture rather than try to ban and make these giant sweeping, we're all going to be carnivores, we're all going to be vegans, because both of us know that's not going to happen. And so if we actually put a realistic approach, we could get more done.
Veganism, animal activism, and I honor people that care enough about the suffering of a creature to go stand in front of a pig truck. It may seem extreme, but they're doing it from a compassionate viewpoint. But I don't think any of that's going to really move the needle. It's market forces and it's technology. So, would you eat a ribeye made by Memphis Meat? And I don't have any stock in Memphis Meat. It happens to be a startup owned by a cardiologist in part, brighter than me, that can make a ribeye that genetically is a ribeye, but just doesn't require a cow's life to be sacrificed. And they've been talking maybe by this year or next year products will be out. Now, we all have our concerns about how engineered that is. And we certainly know Impossible Burger and Beyond Meat burgers are, they're processed food. They're shifting, public palates that are leading to less animals being used. But I think quality and health is going to get better. I think it's the inefficiency innately of CAFOs will drive technology. And no, we don't want to be eating, fruit strip beef jerky that's made in a factory, but that movement's going to be happening. So, the the CEO, I think it's a Beyond Meat, says 2030, the meat industry will be pretty much a niche like you're talking, a farm like Joel Salatin, I think is his name, with regenerative farming. But the 90% of meat, chicken, and all in America makes is probably going to be technologically somehow created without the environmental impact and animal rights. It's just not an efficient business. I think that's going to happen. And I will tell you, he's financially driven, and he's not a animal rights activist driven person. He sees the future. Not everybody agrees, but it's got to change. I mean, if it's just about just a pig farm polluting the water in North Carolina, I mean, we can only tolerate that so long. So I agree. I think there will always be the ability to hunt and the ability to support progressive, animal meat farmers. But I think the bulk is going to shrink, and it'll be technologically driven plant-based food and technologically driven animal mimetic food. I mean, genetically identical. It's an interesting question because there are ethical vegans that say, you show me a ribeye that was in a lab that's, biochemically identical and pure, but an animal didn't suffer, I'll eat it. I mean, you may get some of these, aggressive, compassion-driven people back at a Mediterranean diet or a mixed diet, or who knows. I mean, I actually, think that's likely to happen in the next 5 years.
Yeah, I obviously have a little bit different opinion on that. I think Ethan Brown or Patrick Brown's belief that we're going to wipe out the animal agriculture industry by 2030, 2035 is very, very optimistic. I think one of the things that maybe you don't understand is how those foods are produced and the inputs that go into them. So to create the protein that goes into those big bioreactors, you can't make protein out of air. So you require protein inputs. And where do those protein inputs come? For every gram of protein that you put into the meat, you have to obtain protein from largely a plant-based source. And so it's going to be soybean crops. It's going to be pea protein crops. Those things are environmentally destructive, as you probably know, with the monocrops, with the pesticides, with the herbicides. So I don't think you make an environmental benefit. You might make the argument that there's an ethical
smaller, just a smaller water, dramatically lower water consumption. But
well, I mean, again, that's only if you discount rainwater. 98% of the water that goes to cows is rainwater. That's what's in those calculations. And that rain falls regardless. So when we talk about blue water, it's a very different metric. And then when you start looking at nutrition versus calories, and we're talking about critical nutrients, lysine, leucine, zinc, then the numbers come very differently. Joel, unfortunately, and I think we should do a round two because I think this is good.
Okay.
I have to go do another podcast, but
Cool.
Let people know where people that are interested in learning more about the vegan diet or your clinic or heart prevention. I think those things are very important. I think you do a very important service to people. I think that, like I said, you and I would say lifestyle is super important. And then how do you manage risk? And I think, we agree on, like I said, 98% of this stuff. Where do people find you?
I just want to ask if you can hold an hour-long plank. Can I stand on your back while you do it? I can't hold an hour-long plank. I work out every day, but you are setting. Anyways, I'm a clinic in Detroit, but website drjoelkahn.com, drjoelkahn.com. I'm not here to proselytize. If you have a medical question, I'll put it in the chat. But people email me, and I don't charge people for a quick question, because if you wanted to know how do I get some of that blood work or something, I'm not trying to convert you and change your mind, but I just have huge experience doing advanced lab panels and could direct you what to ask for and all. But I'm delighted that you're on the process, you and others, of doing a study. Good luck on your next podcast. Let's trade books.
Sounds good, Joel. All right, take care. You guys have a great day. We'll see many of you guys tomorrow. Don't forget to fill out the survey. And thank you, Joel. Take care, guys. Bye-bye, everybody.